Right, well, good afternoon, everyone, and welcome to a series of two webinars. Just interesting reflecting on that. I'm wondering when a pair of webinars becomes a series. Anyway, that someone can put that in the chat box and inform me later. Anyway, we have a series of webinars. This started last week. We've got two this week that are focusing on the clinical aspects of discharge and timely discharge from hospital. I'll introduce my colleague Anne-Louise shortly, who's going to be presenting on today's webinar, and we'll be linking this with another webinar at the same time, so 1 till 2 o'clock on Thursday, which we hope many of you will also be able to attend. We will be recording the webinars, so they'll be available to watch on demand. And the focus of our webinars this week is around optimising timely discharge for ward-based patients. So I don't know if you've got the slides to go, Crystal. If you could load the slides up, that'd be great. The aim, or our aim this week with the two webinars, firstly, is today's webinar is going to focus on some of the clinical leadership and the clinical decision making around discharge. And then on Thursday's webinar, we're going to take an MDT approach. We're delighted to be joined by Lynn Quinney from the Patient and Carer Network as well. So we have a patient voice in the presentation and the discussion on Thursday. And we're going to be looking at everyone's roles and responsibilities once a decision to discharge has been made. But today's session is going to be led by Anne-Louise Schokker, a colleague of mine who's a clinical associate with ESIST, but a consultant geriatrician and associate medical director at United Hospitals Lincolnshire, where she's been leading on a lot of the ward round work and linking that to safety and timely discharge. Just in terms of the scene setting, so next slide, Crystal. So I think it's important that we acknowledge the huge workforce challenges that we're all facing at the moment, both in and out of hospital, with large numbers of staff having to self-isolate, a real lack of continuity, and a pretty tired and exhausted workforce. This comes at a time when we've had a national ask to increase the discharge of patients who meet the criteria to reside. We know that there are challenges with the data accuracy around the criteria to reside, not to mention the validity of the tool, thinking and reminding ourselves that this is a tool for improvement that's been subsumed by performance. One of the key things for the next two webinars from our perspective is to align ourselves with the common ground. We have targeted specifically these webinars towards frontline clinical staff, and we really want to highlight the importance of patients leaving hospital as soon as they are ready and able to go, so that we can get the right patients into the right bed at the right time. And I don't mean that to sound trite or cliched, but I know that's what we all aspire to do. So I'm going to hand over to Anne-Louise, who's going to talk us through some of the work that she's been doing and the importance of clinical leadership in getting timely discharge. At the end of the seminar, there will be a handout, a digital handout that Crystal's kindly put together. We've got a number of tools available that you can download, print, circulate and share with your clinical teams. They're available on our NHS Futures platform. If you've not already done so, we'll put something in the link so you can email us and we can get you access to the Futures platform. But hopefully these tools will be helpful for your clinical teams, and most of them have been recently updated. So Anne-Louise, without further ado, I'll pass over to you. Thank you.
Thank you very much, Andy, and thank you, Crystal, for hosting the slides. So what I wanted to talk a little bit about today is something I'm really passionate about. I led a project on my clinical area because I wondered whether increasing the consultant impact into the ward environment above and beyond us visiting, seeing the patients, making a decision and then tootling off and leaving the ward to get onto it, whether us having more of a daily presence, standing alongside our ward leader and multidisciplinary team, would have a positive impact on patient outcomes, the ward and processes and the team experience. And I felt that I would like to demonstrate whether it had a benefit for ourselves as consultants and clinicians, our patients and our colleagues. And also on the call is Jo Gregson, who was the therapy team leader on the ward, a senior physiotherapist at the organisation. And if we can go to the next slide, please. I just want to describe a little bit about how we approached the improvement project. So the ward we did it on was a 24-bedded acute geriatric medical and mental health unit. So what does that mean? Long title means we looked after extremely frail, poorly people, predominantly with dementia. And these are complex patients, complex medical issues, complex social and therapy needs, who traditionally would have a much longer length of stay than a general medical ward. So what we delivered was daily consultant review of all the new patients before the 9 o'clock board round. This was important to me because I kept hearing in the 9 o'clock board rounds, it's a new patient, we'll discuss them later or tomorrow. So immediately there you've lost a day of that person's admission. We shared information with the therapy team before the board round. So, for example, if I'd seen a patient who I felt perhaps would be medically optimised fairly quickly, but they needed a therapy assessment related to mobility or a fall, I'd be able to talk to Jo and she'd be able to prioritise the work to maybe see the patient before the 9 o'clock board round, which meant right off bat, the whole MDT was singing from the same hymn sheet and we had a clear plan straight away of what the direction of travel and which pathway that patient would be taking. The consultants led the MDT at 9 o'clock every day, and every member of the MDT was empowered to speak up, contribute and provide challenge to each other of a robust nature. The consultant and the ward leader and senior nurses reinforced in the board rounds the key messages and stood side by side on this about once the patient is no longer receiving treatment they can only have in secondary care, then the best thing we can do for that person is to help them have care close to or in their own home. Home is best, and it is important to set your dates really early and assume optimal recovery. Always work to that.
That's Gordon Caldwell here. I'm interested in your predicting how long the person will stay, and I find it quite easy as a consultant on the first day to say whether it's likely to be 3 days, a week, or a month the person's in hospital. So how do you get that?
I think there's a big chunk of clinical experience, Gordon, you're absolutely right. But I think, and I'll go on and talk about this, stepping down treatment. I mentioned assume optimal recovery. Most patients, if they're eating and drinking, don't need intravenous antibiotics for more than 24 hours, and you might want to monitor them for 24 hours to check they're stable. So you can start predicting that that's a sort of 48-hour active treatment and monitoring in secondary care, and they may need some other assessments. So you can sort of plan that's a 2 to 3 day admission off bat of what you would expect the patient's recovery to be, to the point where they're on treatment they don't need to be in secondary care for. So I've sort of slightly fudged that answer that it is clinical expertise. Clearly, I was working in a non-elective medical ward with unselected, a vast range of things. I would say it becomes harder when patients don't follow optimal recovery and other things start coming out, and you have to be agile and change your plan accordingly. So I think longer admissions actually become a little bit harder.
Yeah. Certainly, I think as consultants we start asking the question, how long do we expect you're going to be in hospital, and giving people a framework on the first contact, that definitely makes people think that we're really working towards them getting out of hospital and getting home.
And it creates an expectation, doesn't it?
Yeah.
I think that's really, really important. So I was up to discussing about the framing within the board round and describing to juniors. The juniors find important what the consultants find important. So if I'm reminding my juniors to do discharge summaries early and start that process, they will, because I don't believe it's acceptable for a patient to be waiting 8 hours after they've been deemed medically fit and everything is ready for them to leave hospital for them and to be waiting for paperwork and medications. And similarly, book transport early can always be cancelled. Same day requests are hard to transact in some organisations. The mantra of morning discharges are better for our patient going home. Of course, it's better for a patient to be settled early in the day. They have the opportunity to access healthcare professionals if they have any questions about their medications or problem. And it's also better for our next patient to come to us when we're all around and we can assess the patient, refine the plan, and even get the diagnostics that day. And then the final question in my mind at board rounds is, can our patient that's been going home be cared for in the last hours of their hospital care safely and comfortably in the discharge lounge, meaning we can receive our next patient earlier? And those would be patients who are waiting for a care package that starts in the afternoon, for example. Next slide, please. Permission. I think it's very important within a clinical team to have permission between consultants if they're sharing a clinical area, between the consultant and their junior team, and also between the consultant and the other multidisciplinary professionals. And what I mean is permission to help make decisions on each other's patients. So patients and the team are not waiting for the next board round or visit for a decision to be made, because sometimes teams will hold information and results and wait for a ward round, and then have lost 1 day, 2 days. So giving each other permission means there's never a delay for agile senior decision making when somebody else is on leave or delivering other clinical commitments. We had a proactive discharge coordinator who would obtain collateral histories on our complex patients from care homes before they were discussed at the board round, meaning that we were cited on very early if there were issues in the community that we needed to engage system partners with or put in additional support, rather than finding that out on the day of discharge. We delivered a second afternoon board round, which was registrar or consultant led, which helped decision making and driving forward plans and actions. Same day senior review for new patients where possible. And finally, this may sound a little bit airy-fairy, but we had Fabulous Friday where the team would bring in cakes and treats and celebrate the end of the week. And we would invite visiting colleagues and social care staff to join us. This is really important stuff, actually, because this is the social glue that holds a team together. And when you're working at pace, which we were, it helped embed the trust between team members. It helped build psychological safety, that ability for all members of staff to speak up if they're worried about something, or even better say, I think we might be able to do this better. What do you think? And those conversations over a coffee and cake pre-pandemic, I hasten to add, really built psychological safety in the team. So I think that is an incredibly important thing. Can we have the next slide, please? So what were some of the outcomes? It's not just that we ate cake. I put through SPC charts our discharge rates, and we found we had a statistically significant increase in our discharges from the acute ward. The top graph does not include our transfers to rehabilitation, so our overall ward turnover was even higher than this, which is reflected in a later graph. We also found that we were using the discharge lounge far more at a significant level, meaning we were getting our next patients earlier in the day. The next slide, please. So my length of stay went from nearly 9 days to 5.27 days, which was a nearly 4-day reduction in length of stay, which was sustained. And the other consultant who joined in, their length of stay reduced to a similar order. And what this meant was the bottom graph is comparing similar sized acute geriatric wards with the number of TTO discharge letters we were doing. So we were doing at least 50% more, and in some cases over 100% more activity than like for like clinical areas. If you can show the next slide, please. And I think a very reasonable question is, when improvement projects are starting to deliver outcomes of improvement, is this related to the process or is it related to the individuals delivering the process? So can it be spread? And what we did was use the News 2 tool, and we rolled it out across the organisation. I did it myself with one of the very senior nurses, and we visited every MDT and spoke to all members collectively about the principles of these questions of whether our patients need to be in hospital. So we delivered education around this. And then we also implemented a senior discharge support round. And what that meant was a couple of senior clinicians, you have to be careful who you choose, visited every ward area on a rolling programme to meet the MDT, to talk through their patients and provide a clinical conversation about whether the patient could be managed in a different way. You have to manage those conversations, but they're an opportunity to educate. Some clinical teams are less aware of newer pathways or newer service improvements, and you can really champion and talk about OPAT and SDEX and virtual wards now and hot clinics and thinking differently. So we found our length of stay across all the wards did show a significant reduction. And although this wasn't the prime directive for doing the improvement project, for those that are interested, the geriatric service line was in a deficit position when we started, and then we moved to a position of 1.4 million over plan. Now, the cost to deliver this was one additional PA between two consultants, because we weren't doing the very large ward rounds a few times a week. We were spreading it out, and if you every day you're seeing your new patients, your poorly patients, those that need a decision to go home, you're sort of chunking it up that everybody's seen regularly, but it isn't in that sort of very long 4-hour ward round fashion. And we also found our costs decreased, and I think that would be through, and I do recognise the cost decrease, we did it through de-escalation of IV antibiotics in a timely fashion, and because we're geriatricians, we really love de-prescribing and thinking about what medications somebody needs or is no longer getting a benefit for. And we also think very carefully about whether our diagnostic tests we're booking are going to alter the outcome for our patients. So there was a bit about decreased consumables, decreased diagnostics, but also increased patient, nearly 1,000 patients increased through the service line. Next slide, please. And my final slide about the outcomes, I mentioned that I was interested about compassionate leadership and the impact it could have on ourselves and each other. And we found that our short-term sickness decreased significantly across all staffing groups by 5%. And the bottom, I do apologise, they're kind of the wrong way round, which is my fault entirely. On the right is the 2018 National Staff Survey results, and you can see that sadly there was a sea of red there, and during the pilot year we moved to a sea of green, and there was a much better atmosphere with real engagement from everybody, from all professional groups on the ward. Next slide, please. So I was trying to reflect on the things that I thought probably had the most impact. And I think the consultant-led board rounds with the second early afternoon 20-minute catch-up is up there at the top. Where indicated, therapy assessments and the decisions as early as possible. Seeing new patients as early as possible and before the first board round is the best, because today's work today, some people take to be today's diagnostics today, but it isn't. Doing a test doesn't change anything for a patient. It's the decision on the outcome of the test. So if you're booking it at 9 o'clock in the morning, you've got a better chance of getting it the same day and then the decision. Permission to make decisions within the team on patients and across teams. And then the clinical leadership and visibility, leading the board rounds, driving the plan, making decisions early, and driving the key principles of home first, discharges. And I want to comment on the educational opportunities. A lot of people who haven't worked in this way do describe it will be emasculating for the junior team that they're never left alone to make decisions. And I don't agree, because every contact's an education opportunity, and we found our GMC junior doctor feedback improved. We gathered feedback from them. They felt supported. They felt they knew they could make a decision. They knew that they could come to us about any concern, that we were accessible, but they also felt empowered to review new patients and then present them to us the same day. So then we're doing case-based discussions, we're doing e-portfolio assessments, and actually there were more educational opportunities by us being available and present more. Next slide, please. And I'm a bit known for being a broken record, so I thought I'd just describe my mantras, which were: what treatment or care are they receiving they can only receive in hospital? Can treatment be stepped down safely? Would I admit them from clinic as they are presenting now? And sometimes that's a killer question to ask yourself, because admitting somebody from clinic is a whole heap of hassle. And sometimes keeping somebody in hospital is the easiest thing to do, but actually not the right thing to do. What does our patient want? And I'll come back to that point in a moment. And my final mantra is just pick up the phone. E-referrals are good for some reasons, but I see time and time again, referrals go in and then clinical teams wait 1, 2, 3 days for a specialist team to come, only for the specialist team to say, it's fine, we manage this as an outpatient, do the X, Y, and Z, and we'll see them in clinic. And we've lost three days of that patient's life, kept them in hospital waiting for that. So picking up the phone, I believe, passionately, is really valuable. It builds relationships between teams. It's educational for me. And it also means next time I know what that specialist will want, so I can do it quicker. And then finally, and most importantly, is if it's an emergency and I need specialist help, I'm going to phone them and they're going to help me quicker to help the patient. And those things are, I think, are very, very important. Next slide. Okay, so on to questions and answers. So thank you very much for that, listening to me through that whistle-stop tour.
Thank you very much, Anne-Louise. A huge amount of information covered in a very short space of time. I'd encourage everyone to put any questions you might have in the chat box, if you wouldn't mind. I'm just going to pick up on a couple of points, if I may, Anne-Louise. So Rachel Ingram has highlighted the importance of community services as part of the management plan and things, and referred to sort of, or alluded to sort of considering, does the patient need a hospital bed rather than a bed per se, I think. Rachel, did you want to expand on that further?
Yeah, no, I think you're right. What we're kind of saying is there's so many community services out there now that are actually doing a lot of work about admission avoidance and also helping support step downs. And I think it's just making sure that we consider the community services that can be part of that management plan from the moment they kind of come into hospital, so that we can then quickly support people to come out, whether that's crisis response, whether it's virtual wards. You know, everywhere's got their sort of nuances and their specialities, but really linking in and collaborating together, I think, is key to getting people out as quickly as possible. And I do think it's that standing at the end of a bed almost saying, why do they need a hospital bed? Do they need that, or can we actually support them at home with community IV, community fluid? So I think it's just understanding what that skill mix is out there and what specialities you've got.
Rachel, 100%. You know, having started doing the virtual wards, I've started doing the frailty virtual ward and working really closely with the community teams. Heroes, absolute heroes. But I think, and Andy and I had this conversation when we were prepping, I believe secondary care teams don't have a great understanding at the moment. It's going to change with the virtual wards of the level of care that's being delivered by our community teams. And as we build that understanding in secondary care, Rachel, the trust will build. I keep talking about relationships, but even now out of our virtual wards, like we get phone calls pinging, what do you think about this? Can you take this patient as an earlier step down? Crucial. It's crucial.
Thanks, Rachel. I don't know if you're able to join the call on Thursday, because we want to explore this a little bit more on Thursday. So if you are able to join the webinar on Thursday, that's one of the areas that we want to pick up on. And just from a personal perspective, the other thing that, you know, for all of us on this call, we're probably familiar with a lot of the language that we're using. But when I'm on the wards, most of the junior doctors don't know what STEC stands for. They've never heard of D2A. They don't know what community services actually is. So on Thursday, we want to explore some of those, if that's okay. Anne-Louise, Gordon raised an important point around sort of spreading this sort of leadership amongst more junior members of the MDT. So for linking into that, do you feel that this has to be consultant delivered, or can it be consultant led?
So if I take Gordon's question and then segue into yours, Andy, I've always viewed becoming, particularly my registrar training, it was like an apprenticeship of watching what the good consultants did, and thinking about how I was incorporating that into my mental model of how I was going to be doing it. So I think, how do we train? By being visible and being consistent and approachable, we are role modeling. The opportunity then from that, I used to ask registrars to lead the ward round as well, or present patients at the board round. So it's a real teaching moment when the registrar saying to the registrar, you're the consultant today, I'm scribing for you. It's your gig. So I think there are ways when you're there and you've got you're in control of the ward and what's happening, you can give those roles to other members of the team and mentor them, and then give feedback and use them as training opportunities, and leading the board rounds. So I would say that about Gordon's question. Does it need to be consultant delivered? No, it is the answer, but it does need to be consultant led. So it's about the leadership. You set the plan and your team is empowered to transact that plan, but they also know how to respond if something's going off course and how to come back to you. I do believe I've mentioned the role modeling. When your team sees you say, I'm going to pick up the phone to Dr. Rochford because I'm worried about this gentleman's anemia or whatever. And it is what they see is it's so important to me. I am taking the time to pick up the phone and have that conversation myself. So I am leading and demonstrating the importance of the task. The second bit is the team then sees how to have that clinical conversation, how to frame the information into the clinical question to get the response. Then we can discuss afterwards, well, Dr. Rochford has said he's happy with what we're doing, this, and this. And then we get the feedback and we can discuss the outcome of what we've done, what we could do differently. So I believe the leadership can lead to you train your team. So then that becomes part of the team culture, because culture is what happens when we're not around, right? So you've set the expectations. So I absolutely believe in the leadership in terms of expectations, outcomes, being approachable. Yeah. I do go on about leadership a lot, Samantha.
Thanks, Anne-Louise. I totally agree. And lots of support in the chat around that. I think just for the doctors on the call, remember for your junior doctors, we always used to do so work-based place assessments. So used to do mini KEXs and those kind of things for their portfolio on their ability to do discharge, to run the board round, writing TTAs, those kind of things. It adds a bit of value to them as well. And it also gives you a little bit of reassurance that they're doing the right thing, and you can sort of nudge them as well and support them at the same time. Arvin has raised a question about essentially pushing and pulling between community and the wards. If it's okay, Arvin, can I postpone that question till Thursday, if that's okay? I hope that's not too cheeky. There's the we've also had a question from Ruth Harris on the call about Fabulous Fridays and how you've been able to maintain Fabulous Fridays with virtual cake and virtual coffee in this new virtual world. So how have you managed that, Louise?
I don't know, is this a really honest, vulnerable answer to that is probably not as well as we could. It's been really hard, hasn't it? All connecting virtually. And board rounds have often become virtual. But as you say, a virtual get together with a coffee to talk about what's gone well, what hasn't gone well, and making sure those touch points remain. When you're on a clinical ward, you still get to see people face to face. But it's really challenging for that well-being offer, isn't it? So I think you've touched on it. It's about making sure there is a protected virtual time that anybody can drop in, and setting it up in that fashion with your team to create a space for people to come and just drop in what they're worried about or what they want to do. But it is a challenge, and if anybody's got anything they've done that's overcome that, I'd be really keen to hear it.
Thanks, Anne-Louise. I guess if people could put their thoughts and ideas in the chat box, that'd be absolutely fine, and really appreciated. There's a question from Jane about criteria-led discharge, and this links to a question that I wanted to ask, if that's okay. So one of the questions is, from my perspective, and Jane, forgive me, we will link this in just a second, but Anne-Louise, do you think this is an approach that could work across all specialties? And particularly linking with things like criteria-led discharge and things.
So, Jane, criteria-led discharge, absolutely. So my plans will often include certain parameters, and if they are met, the patient goes home. They don't wait for a review. So it's empowering. I keep talking about empowerment. So the nurses can discharge the patient if the patient's been afebrile for 12 hours or whatever. So absolutely, really clear plans, and I've tried to rolling around how to articulate this. My plans are a bit like a tree. I was describing it to Andy. We've got your trunk of why they've come in, and then your first plan has these different branches of what you're doing. There's treatment, and then if there is a response, do A. If the response is this, do B. And similarly with diagnostics, if the test shows this, the patient can go home. Criteria-led discharge, if it shows this, do this. And it kind of all branches off. And if you offer to the team some of what those branches will be, they can then transact that. So the trust and the permission for the whole team to do that is important. And I think expanding into Andy's question, so does it work across other specialties? So Simple surgical cases, I would think, are absolutely prime for criteria-led discharge. We know coronary Cray units will run elective angio lists, nurse-led discharges. And I think there are some principles about this that apply to everybody as a clinician. So asking what your patient wants applies to everybody. Clinicians often worry, keep people in. The easiest to talk before about the risk being the patient's, not it's the patient that holds the risk of being discharged, not the clinicians or anybody else. Patients, we are incredibly privileged that we are trusted as NHS employees so much, and our patients trust us and respect us as clinicians, the specialists who know best. Therefore, they will often go along with whatever is recommended. But if you frame it to your patient, well, you know, if there's a way for us to look after you and deliver the care that you need in a safe way at home, would you like that more? Most people will go, yeah, I'd much rather be at home, thank you very much. And particularly frail older people are often desperate to be back in their own home, and we just don't ask the question often enough or facilitate it. So I think asking the patient what they want applies to everybody, Andy. I think all clinicians should be able to recognise when a patient has something that is untreatable, or their symptoms are coming from an underlying diagnosis or constellation of comorbidities that are essentially untreatable. They're palliated. I think that the other reason it should work for all specialties is we often hear frustrations from specialist teams about having the wrong patients in their clinical areas, not getting all their specialty patients in, and then having specialty outliers and lots of ward referrals from other teams struggling to look after the specialty patients. Well, control your ward. If you work in this way, you control your ward, you know who's going home, you can pull. And you can pull your specialist patients into your bed. So there is a carrot on the end of this stick for specialisms. And then I think finally,
so on that point, Anne-Louise, I'm just going to come in because just to highlight again on Thursday, this is an area we're going to explore, because in order to do that, there need to be really robust clinical sort of clinical operational processes in order for that to happen. Yes. So we talk about it a lot, but actually at the shop floor, when you've got 12-hour breaches coming out your ears, people just put any patient in any bed, and we'll talk a bit on Thursday about how we can optimise that.
And this is where clinical leadership comes back in, because most ops teams, if you say, well, hang on, I know there's a D2A breach, but actually this patient really needs us, and if we take them, they're going to have a shorter length of stay, and we give alternatives, and we give clinical leadership and decision making and input into that patient bed flow management, this process, then it works, doesn't it? Because we've all seen patients going into the wrong place for a short-term crisis decision. It can take weeks to recover that position, purely in terms of operational flow.
Thanks. So, I agree.
And I was going to make one final point, if I may, Andy, about why this works in other specialties, is about getting that paradigm shift to the clinical teams. It's not just the patient in front of them that needs them. If that patient, for every patient in the bed in front of them, there is another patient waiting who needs to come, who will benefit from your specialist team's care. Then there's another patient in ED. Then there's another patient in an ambulance waiting to be offloaded into ED to receive emergency care. And then there's a patient in the community awaiting that ambulance. So actually, it feels a bit like we have a moral imperative to actually think broader than just what's in front of us, about how we can help not just one patient, but there's a whole chain of patients extending out that we can help.
I agree, Anne-Louise, and there's some really good stuff about that from our colleagues Ben and Barrett and other clinical associates about sharing risk across a system. I just Jane who raised a question about criteria-led discharge in Salisbury. I don't know, Jane, if you're still on the call, whether you wanted to share any thoughts or experience from criteria-led discharge.
So we tried to roll this out before second wave last year, and we prioritised it in one medical ward, or respiratory ward, or one surgical ward. As you said, we didn't. We felt in coronary care, it was in the cardiac areas, it was happening anyway. So we took learning from there. Our chief registrar was very proactive in that. It worked really well. It really fell apart when we got to second wave, and we tried to revisit it in the summer, but I'll be honest, the summer was very challenging anyway, and we haven't got back to a place where our staffing numbers really, we feel it's safe to go down there at the moment. I'm just looking at the stuff on the website actually, and it's making me think, I think it's time to really start revisiting this and see how we can do it in a safe way. I think it's the safety netting of the junior, for want of a better word, of staff. I'm actually the Deputy Chief Operating Officer here, so I've got an operational interest, and also a patient. I'm a clinician by trade. I just went into operational management. So I think it's something we need to do. I wonder if it's something we need to maybe approach from a regional angle, so that we learn from each other as well. Because certainly when we did it a year ago, I think it felt quite scary for some of those junior individuals, particularly at the weekends, and that's where we were hoping to get some of the real quick wins, was those weekend discharges, because we all know that the weekends, certainly in rural acute hospitals, things tend to go by the wayside a little bit.
Jane, if it helps, workforce challenges are worse everywhere over the weekend. They're exaggerated everywhere over the weekend. We also know that sort of for criteria-led discharge, the evidence base is in elective surgery and paediatrics, interestingly, so it's always a challenge, more of a challenge for medicine and the medical specialties. I think for me, as a gastroenterologist, there is something around the diagnostic side of things. So if I do an endoscopy for a query GI bleed, for example, not an uncommon request, I can facilitate that criteria-led discharge based on the how I write the report for the endoscopy, but actually often fails to translate into a discharge unless I've picked up the phone and contacted someone as an individual. And it probably comes back, Jane, to your point about the more junior members of the team feeling confident, and I emphasize the confidence, not the competent. It's confidence around discharging the patient towards the end of the day without senior review. So, and Jane, if just for everyone, there is a handout being posted in the chat room currently that's got all our rapid improvement guides and top tips and tricks that are available on our Futures platform. We've also got one on criteria-led discharge, which has been co-written by Leslie Deutsch, who's a consultant nurse in Warwickshire and an associate professor whose research is on criteria-led discharge. It's a really evidence-based resource for people to look at. I'm aware of time and things. Jane's alluded to something I think we're all very familiar with, which is the challenge of the workforce, and that's before well, particularly before Omicron, the workforce challenges were quite difficult. But since Omicron, certainly in London, I think across the country, we've had a real challenge with continuity of care on a day-to-day basis, with teams not knowing whether they're coming or going. I just wondered, Anne-Louise, or possibly even Joe, your colleague, what tips and tricks do you have around how you mitigate that on a ward basis, on a day-to-day basis?
Perhaps if I come in first and let Joe have a thing. I always manage to not answer the question by starting with a different question that's not been asked. I think at a system level, using models of trusted assessors rather than repeating assessments and absorbing individuals' time is important. I think there is something about generic assessments from a therapy perspective and those being shared rather than people working in a silo. I'm sure Joe would describe that. So occupational therapists supporting with mobility assessments. I think we need to, as our therapists are a precious resource, we should challenge behaviours that can creep on wards around, we're going to keep a patient in bed until the physio has got them out of bed. So Joe's smiling, I'm glad I've made a smile. That's not acceptable. We should be finding out about how somebody normally mobilises, provide them with the mobility aid, and help them get out of bed. So don't keep them in bed, creating a self-fulfilling prophecy by doing that, particularly for older people. And then thinking about therapy assistance. So I guess there is a similar principle to consultant-led rather than consultant-delivered, that therapy assistants can help deliver the senior therapist plans. Joe, I don't know whether you've got more to add about how we can stretch ourselves.
Yeah, I think I agree with everything. I've worked alongside you a long time. In terms of kind of the looking at the side of what we can do as therapists. And one of the key things is actually spending the time not just teaching our therapists that maybe are in our team. So like Anne-Louise said, we look at kind of generic working. So in the team that I cover, we don't necessarily have a physio and an occupational therapist on every single ward. We work to trust what each other do, and if the role outsteps our boundaries, then we will go and ask for help in the exact same way that you would as consultants if you need the speciality. So I think that makes a big difference. And also it helps with the trusted assessor because of the fact that we're now giving our advice to social services to try and help with the larger MDT and getting those patients moving. But what we also do is we look to work with the nursing staff more closely to build that relationship in terms of giving them the confidence to get up and to get the patients up and moving before we get involved, because we work a Monday to Friday service that is likely to change in the not so distant future, and we have looked at trialling 7 days. But if a patient arrives on the ward at 5 o'clock on a Friday after I've gone home, there's a potential then that they're spending the next 3 days in bed, which we obviously all know will cause some deterioration in their abilities anyway. So I think kind of building the confidence of the nurses. So what we look to do is spend time with the student nurses and with the brand new nurses when they're supernumerary, to go through bits of handling. When do you need to stand right next to that patient? And I think that can make a huge difference because it reduces the length of stay because the patients are up and moving, and it promotes that getting them up and going and encouraging them to wash themselves. So what do we need to do for the patient and what are we doing because we're nice is kind of one of the key questions that we tend to ask because it makes a big difference.
Thank you both, that's really helpful.
Can I make one point? Sorry, you're so right, I forgot to say that. I always are we doing it because we're being nice or because the person really needs the help? And of course, everybody's just trying to be helpful, but it deconditions frailer patients very quickly by doing everything for themselves. And the other point I forgot to make was about, again, only doing in hospital what needs to be in hospital. So there were days when we used to do OT home visits, wasn't there, Joe? It should take somebody out of the frame for 3 hours. We should be doing D2A, shouldn't we? Really, the majority of time is people shouldn't be. If somebody's well enough to leave hospital to have a home visit, they don't really need to be in hospital, do they?
Thank you very much both. And I think one of the key things is around the leadership by the MDT for the MDT. So supporting each other in these difficult times.